Welcome to tonight's meeting. We're going to be covering a lot of what I consider would be important news from the recent Croi conference. That'll be important to community, but really specifically those of us who live with HIV. I really thought I would glean through all of the science and figure out what might be really sort of impacting the lives of people living with HIV and what they would want to know from this important conference, because there's so much that you could virtually spend days and days exploring it. But before we get started into that, I wanted to make sure that you all knew that there's another talk and I wanted to feature. This one's going to feature a very interesting man named Dustin Duncan. And Dr. Duncan is a social and spatial epidemiologist. And we're going to be hosting a conversation with him with the CFAR. And we're going to have as the sort of moderator for the group, one of the local Black Lives Matter activists that you may know of. His name is Deontay Damper, and he'll be hosting and moderating that conversation for us. And so I will send via the chat the link to that study. Not that study, this conversation. Let me get that up here for you. I'll put it in the chat if you want to take a look at it. You should see it there. There's the link for you. That should take you right to the registration. If you want to click on that link and then bookmark the link and you can fill it out later. But it should be a really interesting conversation talking about how the characteristics of where you live, your neighborhood, can actually impact your health. And we're going to be focusing that all around HIV and talking to him about that. So it should be a very interesting conversation to have. It'll take no more than an hour and you might learn some new things. So please think about joining us on April 2nd. All right, let me get this next slide. And it's hard to believe it was a year ago, 1 year ago, that we found ourselves locked down and scrambling on what to do. And I remember I wasn't sure what we were going to do about our community meetings. And we had the bright idea to maybe talk about COVID-19 and HIV and everything that we know. So our new director, Rachel Bender-Ignacio, gladly hosted this with me. And we spent 2 hours talking to everybody about COVID and HIV and what was known and what was not known and answering everyone's questions. And it just gives me pause to think that a whole year has gone by and there's been so many changes as a result of that, as well as a lot of not so good changes. If you don't remember, at the start of that meeting, we had mentioned of a community member here that was close to many of our CAB members and close to me, a friend, Charles Perry, who had passed away from COVID. And I wanted to make sure that we remembered him. Let's go back. What's going on there? So if you take a moment and think about Charles, think about the people that you may know of who have passed, as well as realize that it's been a year. So today I wanted to focus on the virtual meeting known as the Conference on Retroviruses and Opportunistic Infections. And that is abbreviated as Croi. So when we talk about Croi, oftentimes it can feel like an insider talking, but that's what we mean, the Conference of Retroviruses and Opportunistic Infections. This year was really kind of a dramatic year for it. And I just wanted to feature this first of all, because it really affected me. This was the first year in recent memory that Croi made itself inaccessible to community. It used to be that they would post their talks sometimes within the same day. And as a non-attendee of the conference, I could still listen to the science for myself. But they've taken that away from us. And there was a big uproar that happened when the community realized that this was happening. And we were told by the conference organizers that they were going to withhold the research data from the general public for up to 6 months. And so the HIV activists I know all sprang to life, and suddenly there was a letter to sign on to, and it was submitted to the conference organizers. And we were acknowledging that there were significant changes and challenges that running a virtual conference would bring to these organizers. But we really felt that the way they were choosing maybe to make some money or trying to get recoup their losses by withholding this from us, especially when the bulk of it was funded by us, couldn't be possibly the solution. And so they did make some amends. And on March 10th, they decided to partially reverse their course, and they made available to everybody the abstract ebook. So this is the book of all the abstracts, which are basically the summary of all the science. And you can download that. And I'm going to share that in the chat with you all. Hold on one moment. Let me get this. Where is my, well, I guess I don't have it here now. Well, I will share that with you in the chat before we end this meeting, so you get all of those. But you can look at the abstract book. It's not very fun reading, but if you're interested in the science, it's what we have right now to be able to see all the different things that were available at the Croi conference this year. So we had some influence on how they went through and changed things. But the first story.
How long is that book, Michael?
Say what?
How long is that book?
It's pretty long. I didn't look at the actual total pages because it's an electronic version, so you just kind of flip through it. But it's pretty big. There's lots of science that's presented at Croi. So but it's a good tool to have if you're interested. You can at least read the titles of what the science is about. I think sometimes just seeing all the different things that are being worked on, some of it is way too abstract for me, not being a scientist, but a lot of it is very graspable. So I'll give you that link before we end the meeting, and you can all take a look at that. But the first story from Croi that I wanted to talk about is here in this title. So there was a study that was looking at taking your antiretroviral medication 4 consecutive days each week, followed by a 3-day break. And they found that it maintained viral suppression as well as a daily regimen. So before this study, there were some older studies that kind of looked at the same question. There was the photo study that did 5 days and then 2 days off. And that was with the older Sestiva-based regimens. And there was even taking a treatment breaks, as they were calling them, on weekends for adolescents and youth. And that seemed to work well. So there were some studies that showed that this might be a manageable technique. But this study that we're going to talk about, the Quator study, which was done by the French, was asking, can people with an undetectable viral load maintain their viral suppression while taking medications just 4 days a week? Now think of this. If it was successful, not only would that be giving people a break from their treatment, it would reduce the cost of therapy to about 40%. I think that's amazing. So this study, done by the French, was first done as a pilot study, and it was non-randomized. And in that pilot study, they found that 96% of the people could maintain their undetectable status for about a year. And so that larger study, the Quator study, was a larger randomized open label study and had 636 adults in it. All of them were undetectable, which means that they were below 50 copies for at least a year before they got into the study. And their CD4 counts were above 250, and they had no drug resistance known. So those were some of the qualifications of them entering the study. 80% of the men people they enrolled were men. Their average median year was 49 years, and the median CD4 was 700. So how this study worked, for the first 48 weeks, for the first year, you were randomized to either stay on your daily regimen that you were currently on, or taking your current medications for 4 consecutive days, Monday through Thursday, and then you were going to follow that with 3 days off. So you stayed on your same meds. You were just going to start taking them with this 4 days on, 3 days off cycle. So that was the first year of the study. At the end of that, you had another year added on, and then both groups were going to be going on to the 4-day, 3-day. So those who were doing the daily treatment got to switch over to the other way. And so everyone was doing 4 days and 3 days off. So you had the people who went from daily to intermittent, as well as the people who were always doing the on-off scheduling. So, and what did they find? Well, they found that 92.7% of the 4-day group and the daily to intermittent group, 96.1%, were still undetectable after 2 years. And some of them did have virologic failure. So the 4-day group, it was 4.2% of the people, and the daily to intermittent group is 2.0%. Now, those people who did experience virologic failure, 5.3% of them were on NRTIs and 2.4% were on integrase inhibitors. So the NNRTIs, if you're not sure what those are, here are the names: Intalence, Sustiva, Viramune, Endurant, Pifeltro, and Rescriptor. The integrase inhibitors you may know because you may be on them. Acentris, Tivicay, or Triumec has dolutegravir in it. These drugs are also in Stribold and Genvoya and in Biktarvy. So these integrase inhibitors were also important. But what the study found was that this was generally safe and well tolerated using either strategy, and that there were few differences in the rate or the type of adverse events in either group. So the 4-day group also had something interesting. They had a statistically significant improvement in their kidney function. And another smaller study of this group also showed that they were no more likely to have detectable HIV in their semen compared with people on continuous treatment. So that, of course, would be a concern with transmission and the U equals U messaging. And it seems like this strategy did not harm that in any way. So the efficacy of this 4 days on, 3 days off was sustained by 96 weeks with a low rate of virological failure, particularly among the people using the integrase inhibitors. So this is the man who was presenting at Croi, Dr. Roland Landman. And he really emphasized that this strategy would reduce the cost of treatment, again, by 40%. And he says that it represents a real workable alternative to daily maintenance therapy. So that's the first study, and I wanted to stop there and let us discuss it. So what do you guys think?
That's amazing. Especially as much as meds cost.
Yeah.
The only question, if that ends up working out, are the medications the pharmaceutical companies going to charge more because they're selling as much?
I'm not sure I heard you, Starlet.
Is that going to cause pharmaceutical companies to charge more for prescription?
Oh, that's a good question. I don't know. I don't know. Of course.
And you said,
go ahead.
And you said that the resistance to medications going to the 4 days on, 3 days off was minimal?
That's what they say, yes.
Okay, because some people are they're to the point to where they're tapped out and only left a few medications left that they can take. Some are down to their last ones that they're on. So
right, and those types of people were not enrolled in this study, and I would imagine that this strategy would not be advisable for someone who is in that situation.
And how many women were enrolled in this study?
20% of them. So if we can do some math, there was 636 people. 80% of them were men. So it was predominantly men. 20% were women.
Okay. So you're looking at probably 80?
I'm not good with math, especially not on the fly, but let me check.
Let me do my calculator.
Yeah.
About 130.
Yeah, I was going to say it's like 130.
636 times 127.
120, yeah. There we go.
And to that point, then, are the conclusions that they made applicable to the women in the study?
It's a good question. Was it powered enough to answer this definitively? I don't think so, but I don't know if Rachel has an opinion on that.
I don't know what their power was, and it probably wasn't. The one thing I would say is that in terms of HIV reservoirs, women tend to have less inflammation and a lower set point. And so I think this would not be a scenario where I'd be worried that women would be at higher risk of this not working. I actually think that If anything, this might be, I wouldn't conclude with this amount of data that it is safer, but I would say that given what we know about women and reservoirs and hormone interaction with reservoirs, it's probably as safe for
Right.
women.
Is
Was
anyone,
there-
go ahead.
Was there any discussion, or did more people report more missed doses or more challenges in maintaining adherence with an irregular treatment cycle?
That's a great question. And I did not have full access to the presentation, so I don't know if they covered that, but I do not think, I think they would have mentioned something about that in the research that I've done, and I did not see anything about that. So I don't know if they did any sort of questioning like that. But that would be a great question to see if this 4-day, 3-day led to people missing more doses.
I have access to it, and I'm happy to, while we keep moving on, I'm happy to go see if I can pull up the slides and see if I can share that.
Yeah, beautiful. That would be great.
Yeah, the thing I would say from a provider standpoint to answer Lori's question is, or to say, Lori made the comment that it might make it challenging to maintain adherence. I haven't tried this strategy as a provider since this is so new, but we do this, have this sort of shared decision making around on-demand prep. And I think that it's sort of a similar conversation that should be shared decision making between the patient and the provider about which strategy would be preferable to them. And for people who express that this might be more difficult, that it might not be the right option, but for some people it might be.
Right. I personally found this to be interesting, just simply because it seemed to be research that challenged our orthodoxy about pills every day, pills every day, pills every day. Make sure you take your pills every day. You don't want to mess up. You want to make sure you have that. And now we have some science that shows that there might be another potential, and that potential might satisfy some people's needs to take less medicine. Whether that is, for instance, the kidney function question. The research did show that there was an improvement in kidney function when they went to the 4 days on and 3 days off. But again, conversely, that real strong U equals U message, I think also becomes a little bit more challenging, because we're saying here, that you have to maintain your undetectability. But if someone's having some difficulties with this 4-day, 3-day off idea, I just could see potential troubles coming.
Yeah, I mean, I think we are in a place where the medications are better. So there's higher genetic barriers to resistance, and so there's likely a lot more forgiveness
Right.
than there was a decade ago. But yeah, I really think it's important to as was just being said, to really look at, is this something that's going to be workable for you? Or after you have 3 days not taking your meds, are you going to remember on day 4
Right.
to start again?
Right.
Because now you're out of the habit of doing it. But I can certainly see how this would be good for some people.
Right. And I think that's why they were doing the Monday to Thursday. You know what I mean? Like where you had that locked in. It was Monday to Thursday, you took them. Friday, Saturday, Sunday off. Monday to Thursday, you take them. I think that's what that was about.
I think that would be good for somebody like in my position right now with chemotherapy drugs being also hitting the kidneys. I think that would be something that would probably be better for the kidneys right now. They're taking a hit from all ends, So I don't know how much they did in knowing. Do you have any idea how much research they did in knowing when you have other active, God, how do I word that?
Right. Other comorbidities or other medicines that you're
Yeah.
taking? No.
Right.
They didn't have
They
that.
have anything on that?
Yeah, no, they didn't have that in here. And so that's a great question as well. I don't think that this is the end of this research. I think that there still needs to be further studies in this direction to help sort of answer questions that you guys are bringing up. But I did think it was probably the most unique study out of all the things that I was reading, that it seemed like, oh, here was something that was sort of challenging the paradigm that I have so ironed into my head. And so I just thought I would share that and open up with something that was coming out of left field,
Good.
so to speak.
something different.
It
Yeah,
is.
I'm a bit concerned though with the 1 pill a day regimens. They're already trying to decrease the dosage by doing that. And, the possibility of resistance, and also if they correlated weight in it to see, because obviously they prescribe the same dose no matter what your height or weight or anything is. And I wonder how that might play in on this as, you're skipping doses more frequently.
Yeah, my question would be, with the 4 days on, 3 days off, are they gonna have to increase the amount of, that's in each dose for you, or would you stay on your same dose? And my other question in thought on this is, how well is something like this gonna work with somebody who's newly diagnosed that doesn't have a buildup of medication for years and years and
Right.
years?
True. So first of all, those are great points that you made, Kate. And this was again with people who were already undetectable, and it was talking about switching to a different rhythm. So these were people who were already suppressed, switching. It wasn't about starting off this way.
Yeah.
So that part there,
Yeah.
and I forget your former point that you made, the first point you made, Kate.
Oh, if we go to the 4 days on, 3 days off, are they gonna have to increase the amount of dosages in the medications that we're taking, or is it gonna stay the same as what we're normally on?
So the study was looking at the doses, the same doses that you're on now, basically the same pills that you're taking right now, and just switching the way you take them.
Okay,
4 days
Right.
on. So it's using standard doses.
yeah, because the body stores that medication up over time, doesn't it?
It does. You build up your levels. It's like we tell people when they're first taking PrEP, for instance, that they need to take the pill every day for a while before they get the full level of protection. But then once they're up at that 100% level, if they were to miss a dose, like one day, like it wasn't going to really bring that down. So the same thing with taking your HIV meds, you're going to build up to that level.
Yeah. Okay.
So I just wanted to point this as the first study. And I also wanted to just give this little disclaimer. Just because you've heard this here as some research results that we've shared, please don't just take this on yourself to start this sort of regimen change on yourself for yourself. So just because we're talking about it doesn't mean that I'm endorsing it or that we're endorsing it or that it is the end all be all of this scientific inquiry. There's more to come, but I just thought,
Michael,
yes,
how big did you say the N was in this study?
636 people.
Okay, thanks.
You're welcome.
And an
So if
update on
they
the adherence?
institute,
Go ahead, Bill.
Go ahead, Bill.
so if they institute this, how far out are we looking?
Oh, I don't know, Bill. That's a good question. I would still think that we would need some larger study to really sort of solidly be able to say that this works. And I think other factors that are coming, newer agents that are coming down the pipeline, might just make this all void, so to speak. Because like all of a sudden, if you have a pill that you could take once a month, that's gonna just sort of shoot this out of the water. Not for everyone, but you know what I mean? Like there'll be newer ways that we can treat people that will require less than daily pills, which will be also freeing besides this idea.
Well, I think the biggest benefit would be the kidney, the less damage to kidneys.
I agree with you.
Because I'm on other meds that also damage the kidneys, and I have to take a medication to protect my kidneys. But I always worry that that's one day going to wear out. So I think anything that can help might lessen that.
Yeah. No, and I think that's exactly where this type of research might do the best for us. In other words, if we can really find the people who could benefit from this and then apply it that way, I think that would be great.
Are you going to keep us updated if any more research that goes on with this study?
Don't I always?
Well, yeah. But I always have to ask.
Yes, no, I don't mind you asking. Yes, of course I will.
Michael,
Because I'm personally curious myself. So whenever I find out anything, I like to share it.
I was just going to chime in and say I reviewed the presentation, which was a very short abstract, so they didn't include all of their data, but they did not present data on differential adherence between
Yeah.
the two arms. That said, we know that viral loads don't lie, so it's not clear how many, for example, I think the question is, of the people who were assigned 4 doses per week, how many actually went in the mouth, and the people who were assigned 7 per week, how many actually went in the mouth?
Right.
But the viral loads look good. So
Cool. All right, shall we move on to the next one? All right. So this next one might be of concern to a lot of us because this was asking the question about what roles do TAF and integrase inhibitors play in gaining weight for people who are living with HIV. And so tenofovir alafenamide is the drug that this study that we're going to talk about and some other studies presented at Croi link to weight gain. And there were 3 studies of people changing their HIV treatments. So these are the drugs that we're talking about again. These are the brand names: Biktarvy, Genvoya, Odefsey, Simtuza, and Descovy. These all have TAF, what we call TAF, in there. So early studies have used to point to integrase inhibitors as the cause for the weight gain, but these 3 studies at Croi show that TAF has emerged as an independent risk factor for weight gain. And the interesting thing about the 3 studies presented is that each of them asked different questions and they were designed differently, and yet they each came to the same conclusion about TAF leading to weight gain. So it's something for people living with HIV as well as clinicians who take care of them should be aware of, the potential of the weight gain that's going to be associated not only with dolutegravir, but with TAF. So the study that I wanted to focus in on, and so you know, dolutegravir is Tivicay or Triumeq. The study I wanted to focus on was a large cohort study called the RESPOND cohort study. And this study concluded that each of these TAF drugs, as well as dolutegravir, leads to weight gain. So this is one of those large stretching cohort studies. It's basically people in Europe and people in Australia, and they've made one big cohort so they could look at lots of people. And it was designed to answer sorts of questions like this beyond just viral load outcomes. And so this study had 14,703 people on treatment from Europe as well as Australia, and it looked at newer HIV drugs that were associated with weight gain after you started them. And what they called weight gain was at least a 7% increase in your body mass index, or your BMI. So that's what they were calling weight gain. 74% of the people here were male, so 26 were female. 91% were white. 80% were on ART, and of those 80%, there was about 39% of them were taking an integrase inhibitor, which is one of the drugs concerned about for weight gain. So they were followed for about a median of 2.6 years. And during this time, there was 4 weight measurements taken. And the measured weight gain was associated with each drug that they initiated. And then they compared the odds of gaining 7% or more compared to lamivudine. 54% of the people in the study experienced a weight gain of at least 7% of their body mass index. And there were 4 drugs associated with this. One was integrase inhibitor called raltegravir, or you may know it as Acentris. One of them you may know as Intalence. Let me get this out of the way. Another you may know, dolutegravir, which is in Tivicay or Triumeq. And then there's good old TAF that we've been talking about. And there are 5 drugs there that have TAF in it. All of these drugs were associated with that at least 7% increase of your body mass index.
Yeah, and I believe that's true because I know I gained weight with Triumeq and Biktarvy, both.
You had it right there, and that might just be the medicines that you're taking.
Yeah.
So being underweight was also associated with an increase, but in that case, I think we would look at that if you were already underweight, that this would be a nice thing to have a body mass index increase. But also being Black was another associated trait of this happening.
Huh.
So one of the things I would love to point out to you, if you remember a few slides back, how much of this study enrolled people who were Black?
91%.
No, that was white. It was 90%,
white.
91% white, right?
White.
So in
But
other
there's
words,
only
we don't
9%
know the other
black.
ethnicities. We don't know if all the rest of the people were Black or not, but we're talking about a small percentage compared to the larger majority that they got in there. So I don't know how much we can really conclude around this, but again, that would be depending upon the powering of the study. But we didn't get how many people they enrolled specifically were Black. They didn't give me that information, or I didn't have access to it.
I know Black, white, Mexican, Asian, people that have weight gain, weight loss on different HIV medications for many years, including myself. So
Right. So the odds of the weight gain associated with these drugs was higher when dolutegravir and TAF were used together. And dolutegravir and TAF were also independently associated with higher odds of weight gain of at least 30% of your body mass index. So just to show you what that looks like, a normal body mass index is around 24. That would raise you up to 32, which is considered to be obese. So either of those drugs independently associated with a higher odds of that happening for you. Exposure to each drug doubled the risk of gaining this amount of weight too. So that's very concerning. So the thing to take from this study is TAF contributes to weight gain in people who are already treatment experienced when they start taking the drug. And now how it might lead to weight gain and why there might be an interaction with integrase inhibitors, especially with dolutegravir or Triumec and Tivicay, needs further investigation. But I think this was very sobering. And we've already heard from some people saying that they've experienced weight gain when they started some of these drugs. Others there might also be seeing this happen in their lives. They might be thinking it's personal choices that they've been making in terms of their diet, which could also be a factor in it. But definitely, it seems like the medicines that we have, these great new medicines that are doing a great job at keeping people undetectable, that are very easy on the system, they might be doing something about people's weight, raising it. And how this happens, we still need to figure out. Why this is happening, we still need to figure out. But we're kind of getting to the point where we can understand that it is happening. So, I just
Well,
want
Michael, do they know anything? Sorry,
Go ahead.
Michael, do they know anything about the brown fat or white fat?
I didn't see anything about that, Mark. Mark, do you
Okay.
want to explain to people what you mean by white fat and brown fat?
I mean, white fat, is considered not so good. Brown fat is really what can be broken down and will be broken down. So when you have a greater store of, non-brown fat, that becomes a greater problem.
Did everyone hear?
non-brown fat, isn't that where you start getting the buildup of in your cell wall or your walls of your blood flow and all that other stuff, where you start getting clots and all that?
You get, visceral fat, things like that. It's just, they define, that brown fat is easier to burn off than is, non-brown fat.
Mm.
I'll have to look into that later on. Thank you.
Sure.
So did anyone else have any questions or comments about this weight gain?
I think it's interesting that you specifically mentioned that it was experienced by people who were already treatment experienced,
Yes.
because I've heard many clinicians dismiss the whole issue as return to health weight gain. And my experience with my patients is that that is not, the whole explanation. So it's good to have data that actually backs that up.
Yes. And I said that, but that's only because the researchers said that, so it wasn't me saying it. It was the researchers giving that as part of their presentation. Just so we know that it's not my opinion.
Well, it's
Can
not
you-
really surprising because this discussion has been going on for almost as long as HIV/AIDS has been around, that the meds that you take make you gain weight.
Indeed.
Or that,
I think this is a little different though, because this is like the more recent drugs are actually um associated with people becoming sometimes morbidly overweight.
Hmm.
Um, or in the early days when, when people were having a lot of wasting syndrome and stuff, people gained weight back, and that was a return to healthy weight. But this is really people who are not wasted putting on significant pounds that, then could be contributing to other issues like risk for heart disease and stuff. So it is a little bit different than what we were seeing, say 20 years ago.
Thanks for pointing that out. I forgot about the wasting.
Right.
yeah, I never forgot
That
about.
was an important part of
Yeah.
Now,
yesteryear.
now let me ask this. Maybe somebody in here can answer it. I'm on what is it? TIBICAY. How do you say
Tivicay.
that? Tibic. I recently went on that, and I've been noticing some weight gain, but I've also been eating more, trying to change my eating habits due to my bone density dropping drastically.
Hmm.
So I'm not sure if the weight gain is from the medication or the change in the habit of eating. But is there a way, if it is due to the medication, that I can control it by maybe exercise or something?
Well, I would say definitely exercise helps to alleviate some of these problems. I don't know if it will take care of it in terms of making a drastic change in that. But first of all, exercise is just going to be good for you anyway.
Yeah, well,
You know what I mean?
that's
Like for so many reasons. But I think that's the only thing that you really have at your disposal. Like, in other words, if you find yourself gaining weight, besides looking at your dietary choices, exercise choices, those are going to be the two that are going to probably influence your gaining of weight more than anything else. But I don't think this study was looking at people's attempts to lessen the weight.
they were just looking at who was gaining it and why.
They were just looking at, so they were basically looking at this large group of people, and it wasn't like they were enrolled in the study. This was where they could look at people's data since they had joined in and all this data was collected. So there was more like they were looking, statisticians looking at data and determining this rather than people enrolling in a study where there was some sort of intervention.
Okay,
So, but those are good questions, and I know some researchers are looking in that,
Did
that
throw
sort
a
of
couple-
lifestyle choices and how that we might be able to help people lessen that weight.
And it's definitely worth talking about with your doctor as well. I don't know what the reason was that you switched to Tivicay recently, but there are other options as well. And so I don't know if that's true for you, but it's worth definitely, I think most HIV docs are well aware now that these drugs are associated with weight gain. And so they may have some creative ideas.
yeah. The reason why I switched was because I was on a tenofovir, and I had been on it for so many years, and then the recent drop in my bone density. So we were already talking previously about switching my medication. So when the drop in my bone density, that's when I went ahead and said, yes, let's find one that's going to work for me and get me off of that one at least.
Right.
Yeah, so Tivicay is not a swap out for tenofovir, so there may be still other options while staying off of tenofovir. So
Yeah, well,
definitely
she
bring
got
it
me
up
on-
to your doc.
Yeah, I will. They got me on tenofovir and Piltro, PIFELTRO.
Yep.
Yeah, that one in combination. So
Right. That was also associated with the weight gain.
yeah. So
Yep.
damned if I do, damned if I don't.
Well, I think it's just going to require a little bit more sort of an intervention, maybe. You know what I mean? These drugs are really good for a lot of people for a lot of in a lot of ways. I think this weight gain thing, though, is something that everybody's going to have to sort of look at. But again, I just think it's important for us all to realize that if you are on these drugs and you're experiencing a weight gain, it may not just be your dietary choices and your exercise. Although they can be contributing, there may be the biggest contributor, which might be the medicines. So just keep it in mind. And again, I think it's really wise to bring all of these things up with your doctor when you have your visit, just to talk about, because I think these are important for you all to work together, both as healthcare professional and as the client, to figure out what's going to be best for your own health. Let's look at the next.
And I did throw
Go ahead.
links into the chat describing the white and brown fat.
All right.
And there are websites, and they're looking at ways of, harnessing that to convert the white into brown fat. So that might be a way of treating some of these issues that we're seeing with HIV meds and such. So that may be something down the pike.
Cool. Thank you for that. So everyone, if you didn't hear what Mark said, he was saying that he put into the chat feature some links to the two articles about the brown fat versus white fat that he was bringing up for us. So take a look at those links, click on it and bookmark it if you want. So the next study that I wanted to just bring up is the every other month injectable cabotegravir and rilpivirine suppressing the viral load for 2 years. So this news is welcome news. Let me get that. So basically, there was a study looking into the every other month version of injectable therapy. It was called Atlas 2M. And last year at Croi, they showed us their first year of data, but this year they have 2 years of data now to share with us. So that's the big news with this. So they had 654 people who started with an undetectable viral load and who switched from a daily oral regimen into this. And then they also had 391 people who rolled over from the original Atlas trial who were in the monthly arm, taking the shots monthly already, and they rolled them into this Atlas 2M, which was looking at the every other month strategy for using these injectable therapies. 70% of them were men. The median age was 42, and the median CD4 count was above 600. And this study showed that 94% of the people who were once monthly or every other month were still undetectable after 2 years of using these new injectables. So what this proved was that the every other month was non-inferior to the every month strategy. And I'm going to call on Lori. Lori, can you explain non-inferior to us?
Sure. Basically, it means it works as well.
Right. Right. It's not any worse.
People didn't do any worse getting it every other month than they did getting it every month.
Right. Thank you for that. So
Right.
There were 2 people and 9 people who had some virologic failure, which is interesting because if you consider these are injectable forms, it's not as if they could skip a daily dose, which is usually how we think of virologic failure happening. But adherence to the scheduling is really coming into question as we learn more about these injectables. So the every other month strategy, you really need to make sure that you are going to be getting your every other dose or every other month dose on time. There's little room for forgiveness. So you might not have much of an impact if you miss it within a week, but if you go longer than a week, you could have a greater impact on your health and maybe losing control of the virus. The strategy that they came up with for this, they call it bridging, meaning if you were on an every other month strategy, and let's say you had a trip planned and you knew you weren't going to be able to go back to the clinic during that time that you were supposed to get that next shot, they say you could bridge this period by taking the oral versions of rilpivirine and cabotegravir until you could get back to the clinic. So for someone who's very highly organized and adherent, this still might be a strategy to do it every other month, but they definitely concluded that the once monthly was a more forgiving schedule. So if you were due and you missed it for maybe 2 weeks, it was still going to be protecting you more than if you were on the every other month and missing it for 2 weeks. So that's how we're doing it here in the US and in Canada. This new injectable strategy is only approved so far for once a month injections, but in the European Union, they are approved for the every other month. So we'll probably be getting a lot more data from Europe as to when this is rolling out, how it actually works in the real world.
So now us as the HIV positive people, is this shot available to us now, or is it still in the study phases?
So it is called Cabenuva, and it has been approved by the FDA, but I don't think it has been rolled out just yet. I think there's lots of questions about insurance covering it, and it is going to be on the pricier end of things. I'm sure of that. And the other thing you should realize is that it's 2 shots. You get 1 shot in each butt cheek. So the one drug, cabotegravir, in the one cheek, and rilpivirine goes in the other cheek. So it's going to be getting a shot every month, one in each cheek. So 2 shots.
Okay.
So
Are these shots self-administered?
No, they are not. They need to be given in the clinic because you're doing it in your butt, and they need to get into the muscle. So that's why they're being done in the butt.
Was there a difference in the loading dose or the ongoing maintenance dose between the once and twice, or 1 month and 2 month?
No, there was not.
intervals? Okay.
The only difference was between the time of taking it. And it seems that I think the whole idea was that the tail of this new strategy, the way it lingers in the body, was long enough that it could cover 2 months versus a month. But it does start to taper off, and that's why it's really important that you have to be on time with the every other month regimen, because you don't have much of a tail to cover you. Where when you're on the once a month, there's a tail that'll cover you if you happen to miss it and go, for instance, 2 weeks without getting your shots.
So I actually just put this in the chat.
Okay.
But given how much, A, less expensive it is to dose less frequently, and B, less trouble for the person who has to show up at the clinic, why not think about an every 6-week regimen? And then if people are a little bit late, they'll actually be on time for an every other week regimen. I mean, every other month.
Right. That's definitely an idea.
So if somebody would like to be on the every other month, you try and schedule them more or less 6 weeks out. And then if people are late, it's not catastrophic.
Yeah. Although I think you would need the research behind that. We're kind of coming up with our own strategy of dosing, which hasn't been looked at.
Well, if 8 weeks does as well as 4,
yes,
but you're at risk if you go too long, really all you're doing is cutting. I don't think you need extra research to say, well, is 6 weeks less good than 4 or 8? Right. I think the odds of that showing a different result are very close to 0.
Right.
Yeah. Lori, I think the key is that this research hopefully will allow the FDA to approve it for every 8-week dosing, which it's not currently approved for. And once it's approved for every 8 weeks, then it could be administered more frequently. And I have had the exact same thought as you, is let's shoot for 6 weeks. And that way, if somebody, needs to reschedule or can't get off work or whatever, we're not running into problems. But yeah, this was the data that hopefully the FDA will take into consideration and allow us to say it can be as long as 8 weeks.
Right. Do you think that doing 6 weeks would be more difficult to remember? In other words, I don't know for some people, but in other words, every 2 months I would know. So if it was the beginning of the month, I would know I was due. But if it was I was the beginning of the 1 month and then 2 months, I'm in the middle of the month. And then again, at the end of the month, do you think the 6-week strategy might be more confusing?
Well, I don't know how easy it is to get clinic appointments,
right.
But I know often when you call, it's not like you're going to get the appointment for just when you want it. I mean, if you're able to schedule a whole bunch at once,
Right.
so that you have them. And I think it's probably easier to do the longer spacing, but for people who are less organized, that may be something to think about.
Right. And and if you guys have not noticed in the chat, Rachel was pointing out how here locally at Madison, they're trying to work it out before they actually start to roll it out. But the insurance is still a thing that needs to be worked out, and having enough staff to give shots, how to schedule this, all of that is what they want to try to work out before we actually get it implemented, because they wanted to make it really smooth. And I think that's really important. But Jeff brought up a good question. But he brought it up with looking at cabotegravir as a pre-exposure prophylaxis, as PrEP, as prevention. But given the long tail, he was asking, how can you safely stop it when you want to stop PrEP? I know at this year's conference, they were talking about that issue, Jeff. And the one thing that they were suggesting is that as cabotegravir is waning for people who were using it as PrEP, they might actually need to switch to oral Truvada to cover the tail as the tail starts to weaken, to make sure that they're fully protected before they can actually go off and not create any sort of drug-resistant strain of the virus.
Yeah, thanks, Michael. I'd heard that as well, but I mean, the tail can last for 6 months or more, right? Where people
Yeah,
have to switch to. I mean, my thought is people go on an injectable because they don't want to take oral pills,
right.
and once they want to stop, how motivated are they going to be to go on pills for 6 months or longer?
I think it's going to be a difficult thing to work out.
I thought I haven't looked directly at a lot of stuff, but I thought that there was some data presented that showed that there was, in fact, not much infection happening during the uncovered tail. So even though it's kind of scary to think about and looks like it would be a problem, that maybe it was less of a problem than people were worried about.
Yes, that was true. That was said, indeed.
Well,
I imagine we'd need more data than there is.
Yes.
is there going to be any thoughts to people that aren't necessarily live close to the clinic and have easy access to the clinic, but has easy access to some of the, like where I live, Federal Way, they now have the University of Washington clinic out here. And I can go in there and get my labs done.
So you're talking about being able to go there to get your shot? Kate, are you with us?
Well, that's what I was thinking when you mentioned that, because considering the amount of patients that the Madison Clinic sees, it's like with my type 2 diabetes. I used to go to the clinic to get my labs done. Now I have to go down to the lab, and then I have to go over to the anticoagulation clinic to get my results.
Mm.
And that's because of the population. There's so many patients that they're serving. They needed to set up its own separate center. And I think that's probably going to happen with vaccinations as well.
Right, or with these the injectable treatments. Rachel, do you have any comment on that?
Yeah, I mean, my guess is that this will start as something that we do at Madison Clinic and Capitol Hill Medical and, in places that are providing HIV specialty care at the beginning. And then, hopefully as this becomes normal and it's a smooth, path to reimbursement. And especially, I think the big thing is the reimbursement of the administration. So for some reason, when we provide clinic administered medications, getting that paid for, like the nurse time or the medical assistant time is actually harder than, it's different from having things dispensed from a pharmacy. But I do, I think my hope is that it could actually be done in a pharmacy, the same way as you can get vaccines in a pharmacy and not even an HIV specialty pharmacy, but could you go to CVS and pop in the private room for a minute and get an injection. So, we'll see. But my hope is, I don't have any concrete answers, but I would hope that the federal way, there's a satellite for Madison at clinic at some of these places around the Sound that we'd be able to administer injections there at the minimum.
Yeah, I would hope so too.
We're working on it.
Yeah.
Everybody's really excited.
Yeah, I think we're going to see a great change. And so back when I was talking about the 4 days on, 3 days off, that's what I meant. This might be that might be blown out of the water by a whole new treatment paradigm that people are going to rush to. So who knows what will come of that. So this is an example of what was being presented at Croi. I think there was a different presentation strategy where they had a lot of panel discussions. And so I was trying to mimic a little bit of what that must have been like. And so Dr. Diane Havlier here, she was really describing the last decade as described as like potent integrase inhibitors and single tablet regimens. And that's what defined the decade that we just left. And she was describing this new current decade as the one that's going to be bringing long-acting products for both treatment and for prevention. So Dr. Hyman Scott there, he was really excited about them. He was saying he was going to be able to reach people who have challenges with daily dosing, and that having more options allows clinicians to engage with individuals who have barriers to daily pill adherence. Dr. Francois Venter, though, in South Africa, he was less convinced that people who have difficulties taking medications every day were going to reliably be able to attend appointments every 4 weeks or every 8 weeks. He says that these injectables are not the magic bullet for adherence. And his personal practice, he's saying that he's going to reserve this strategy for his most adherent patients. And Hyman countered that he sees two different types of people: the highly adherent and highly organized people who would benefit from this. And he still thinks that the challenges with daily adherence, the people who have those challenges would benefit from this. And he says that he has many patients who are adherent to their visits without being adherent to their daily pills. So there was a little bit of back and forth there. And remember, a key factor in this and how many people are going to actually be turning towards injectables is going to be how much they cost. And so we know that this injectable cabotegravir rilpivirine, the Cabenuva, is going to be positioned at the top end of the price range that they put for the 1 pill a day regimens. So it's going to be a little bit more expensive. And that's going to probably affect who actually gets to use it. They did another little study about some of the cost effective and cost saving pricing. And this was as PrEP, for the cabotegravir as PrEP. And they came up with the conclusion that it can only cost about $3,000 more than the US generic oral PrEP price, which means that generic Truvada right now in the US costs about $83,000 or $88,300 a year, which means that to save money, it could only be charged $10,200. And if it was going to be cost effective, they could raise it up to $11,600. But it couldn't be any more. If it was more expensive than that, it wasn't going to be practical. Now, just to compare those prices, in Europe, the generic Truvada only costs $300 to $600 a year. And so that means their cabotegravir would have to be around $2,000 to $3,000 a year. Just look at the differences in the pricings there if you want to get a little bit angry. So this was this was pricing for the cabotegravir as PrEP, but I just wanted to give you an idea of that. Anyway, Dr. Venter said that, there's great enthusiasm among the patients in South Africa for this, but the healthcare providers have more concerns about how they're going to actually offer this. So the operational challenges. And he says that, like Rachel just mentioned, he's hoping that like commercial pharmacies will be identified and be able to help them give these shots. But he really hates to see that a complicated intervention like this take place of their successful antiretroviral therapy program. And if you remember, South Africa has been a real success story in terms of implementing and getting a lot of people on therapy. And so he's worried that this strategy might actually challenge that and damage it. We also heard from Dr. Panupuk in Thailand, and she says that Thailand's had some great success with oral PrEP, but that's because they use key population-led services. And what that means is basically they have men who have sex with men and transgender women delivering PrEP to their peers, and it's often in non-medical settings. And so they've had a lot of success with that, but using an injectable form of PrEP is going to challenge that because you're going to need some sort of healthcare person to deliver the shot. So they were hoping for implementation research to be done to find out if the long-acting agents could be delivered by lay providers. And she says also a big concern is in Thailand, a lot of the transgender women have had injections of soft tissue fillers in their buttocks. And so if we really can't find any other muscle group, this is going to automatically exclude transgender women from getting injectable cabotegravir. Because right now you can only get it as a shot in the butt. And I found that very sort of enlightening. So all of these issues really shouldn't stop the rollout of injectable cabotegravir as PrEP or both cabotegravir and rilpivirine as treatment.
I have a question, a medical question, which is, in light of what you just shared about the transgender women, if the shot is given high up in the butt, is that higher than the filler would likely to be so that you could still find the muscle? Because usually when you get injections in your butt, they're pretty high up. Is that, I don't know if Rachel could answer that.
I don't know.
I think it depends on the skill of the person giving the injection. I certainly in this, I mean, I don't know if I think fillers in the bum are much less common in the US just because, it's not reimbursed by insurance in most cases and is quite expensive. But in any case, I think it would need to be done by a skilled provider rather than sort of this lay-led, or certainly I wouldn't do like a pharmacist-led, injection. So, yeah, I don't know. I've never given an injection myself in someone who has a filler. I think it depends on how much they have and how much other tissue they have available.
Right. I'd never conceived of it before, so I just was really appreciative of hearing that because it gave me new things to think about. But again, all of these concerns really shouldn't stop us trying to roll out injectable cabotegravir because, if you don't remember, there was these 2 prevention studies that showed that there were 66% fewer infections in men who have sex with men and trans women who use this, and 89% fewer infection in cisgender women in 2 key studies that were done by the HPTN. And the chair of those studies says that these types of results are staggering and that we need to remember that this was really showing that it would be effective for these populations that sorely need protection from HIV. So Raphael Landowitz there. So just realize, go ahead.
So what I'm hearing you say with that last slide is there's a certain population that this injectable is going to be more favorable for?
In terms of prevention, in
Yes.
terms of it being PrEP, I think it's a strategy that works even better than oral PrEP.
Okay.
And so, again, it showed, and when they were comparing it in those studies, when they were comparing the shots versus pills, the shots showed fewer HIV infections by a wide margin. So it was vastly better than the oral PrEP. And oral PrEP is great. So we're talking about going from great to fantastic, or whatever other adjective you wanted to use to be better than great.
Okay.
So just, and his point was that the results were dramatic enough that we shouldn't forget that this was something that we should be trying to go for. Figuring out these questions, in other words, figuring out the answers to these questions. So remember now, there are efforts underway to enable people to take medications less often, both for treatment and prevention of HIV. So on the treatment side, we have islatravir, which is being worked on as a monthly pill and perhaps a yearly implant that would go under the skin. And lenacapavir every 6 months for an injection. So just imagine those as treatment paradigms where you would have a monthly pill or just a yearly implant. I think that is remarkable. And on the prevention side of things, we already have the vaginal ring that's been approved monthly, but they're now looking to stretch that out for 3 months, every 3 months, where a woman could have that vaginal ring. And they're also trying to add contraception to that. So it could be a ring that does 2 things at once, HIV prevention and contraceptives. As well, the injectable cabotegravir, which is hopefully going to be approved soon, since the data shows that it should be, as a monthly injectable as prevention. So just showing you that these are the things that are coming in the pipeline for treatment as well as for prevention. It's all looking like it's going to be a decade of long-acting products to look forward to. But now I wanted to get to some cure news. I don't know if you remember, but over the summer, if you were attended the download I gave from AIDS 2020, we talked about this guy in Brazil that they were calling the Sao Paulo patient. And the news then was that he seemed to be suppressing without using his antiretroviral medicines, and he had gone for 15 months. Well, the more sobering news that has come out for the Croi now is that it seems like he's had an apparent viral rebound. And that's been a year and a half since he stopped and went on his analytic treatment interruption. So the study that he originally joined was trying to look at these intensified drug regimens and to see if they had any way of reducing the size of the HIV reservoir. And that's important, we think, because it might be key to creating the ability for us to remain off antiretrovirals long-term without having a viral rebound. So this man was diagnosed with HIV in October of 2012. And at one point he had a viral load that went above 20,000. And the reason I just mentioned that is to show you that he wasn't an elite controller that we had just discovered after the fact. He was on a 3-drug regimen, and they add Tivicay and Cellzentry to that. Plus, they added a form of niacin or vitamin B3 to his treatment. And he took these for about a year. And then he went back to his original 3-drug regimen. After that, he went on an ATI, he went on a treatment interruption, and he started that treatment interruption in March of 2019. And then again at AIDS 2020, this summer, they had reported that he had lasted 15 months without having a viral rebound, which meant that at the time they couldn't find any HIV RNA, which is the genetic material that they're measuring in your typical viral load test. And he had an undetectable DNA, which is what we think makes up the viral reservoir. He even had a rapid antibody test come up negative, showing that his antibodies were slowly fading away, which is what we would expect if he had no longer any HIV that was replicating in his body. But keep in mind, he was just 1 out of 5 people who were on this regimen to show this, which brought up questions of, well, he could have just been one of these people that we know can get on medicine for a time and then come off, and they are post-treatment controllers, we call them, because they seem to control the virus after being on medicines for about a year or 3 years. So we didn't know if that's what was this person's case. So one of the things that was interesting, when he was on his intensified regimen, they noticed that he had increasing T-cell responses against the proteins on the HIV envelope, as well as the GAG protein, which is one of the major structural proteins of the virus. So his T cells, while he was on the intensified regimen, were responding to the proteins of the cells of the HIV and seemed to be active. But that progressively started to disappear, just like his antibodies started to disappear once he started the ATI. So then in September 2020, he was diagnosed with secondary syphilis, and they took a viral load then, and it still seemed to be below the limit of detection. He didn't seem to have HIV, but by November 10th, he started to feel sick. He had those seroconversion symptoms, and he was diagnosed with a viral load of 6,300. So he seemed to go about 72 weeks off of treatment before this happened. And then so he started early December, he started a dolutegravir-based regimen, and by January 1st, he was undetectable again. So that's the Sao Paulo patient saga, but there's some questions here. One of the things that's come up is that his new strain of HIV, it seems like it might be a new strain because there are genetic differences between the HIVs that's reappearing in his body compared to the strain that he had when he started the study. So there's some genetic differences in the envelope and GAG proteins that they've noticed. And this has brought up some questions. And the questions are, what's going on? Has the virus evolved somehow in his body? Or was he reinfected with a new strain? Or perhaps this is just the reemergence of an ancient strain from a prior dual infection, in other words, when he was originally infected. So these are the research questions that have come up as a result of this. And it's really important that they figure out what has gone on here. The scientist who did this sort of does not think the first case there, the viral evolution, is what has happened. And this was his concluding slide, which I just kind of summarized for you ahead of time. So I wanted to open this up for discussion. What do you think about this study?
I think it's interesting how he went off of his medication, was able to last to 72 months
Weeks,
without a viral load increasing.
right?
But at the same time, him having a different strain of the virus now coming up detected in his body.
Right, which we're not sure yet what it is, but it does seem not to be the same.
Yeah, it that's kind of concerning because it is a new strain because he went off his medications and what was in his body was so suppressed from the medications that going off the medications, it gave the virus enough time to mutate in his body and create this new strain. That could be scary for all of us out there that are HIV positive.
Yes,
Looking at maybe taking some sort of leave from the medication and going back on it, taking our vacations because we've been on it so long.
right,
So that is kind of concerning, but it's also interesting that he could go that long without any detection in his body.
right. And it was 72 weeks again, not 72 months, just to make sure.
72 weeks, I mean, yeah.
Yep. No, but he did go a good long time, it seems. So, and it seems like his T cells were reacting at the start of it. In other words, when he was on that treatment, it seemed like he had T cell responses that were really going after the HIV, but that seemed to wane as he was off treatment. There's other concerns that come up with this specific story, and it's one of those things that it gets into a sort of murky area because it sort of brings up overtones of what happened to Timothy Ray Brown, because there was, soon after he came out, there was some debate. Someone said that he had, one of the researchers was making claims that his virus was coming back, and it kind of murkied the waters around what was going on. And some people believed indeed that he was reinfected or that his HIV came back. And it was kind of an ugly scene. And I think part of that is because of the sort of underlying judgment that some gay men may feel when they hear about reinfection. And there seems to be a little bit of judgment around that. And so I just wanted to point that out because I know I've had some conversations with some people about this specifically when they're talking about it coming back. It's important for us to know if it's a new infection or not, but we have to really be careful the way we're talking about it so it's not stigmatizing.
Yeah, that's true. That's true. People can, they can run with it either way and cause a lot of damage from
Right.
just speaking badly of it.
Right.
So yeah, you're very right there. But I know from personal experience when I fell back into the drugs in 2000, went off my medication, voluntarily went off my medication because I knew I wouldn't continue taking it on a regular basis, which wouldn't have done me any good.
Right.
So I just went ahead and quit taking it. I was off a bit from the early part of 2000 until the late summer of 2002. So I was off of it for almost 2 solid years. And it took over a year and a half, almost 2 full years before I went into AIDS. So, and they don't really know why, but when I went back to Sharon, she tested the virus. It was still the same virus, and it was out of control. That's all it was. So it didn't change or anything. And I don't know exactly how she tested it, but she tested it, the strain it was, and she tested the resistance at the same time to the medications.
Cool.
It's kind of weird how it works differently in each person's body.
I wanted to mention this next study, which is because it's ACTG specific, I figured I'd throw one of those in there. And this was the study where we were putting people on an antiretroviral or an analytic treatment interruption without any intervention being tested. We were basically taking people off medicines because we were looking for biomarkers that might help us predict the time to HIV rebound in people. So this was the sort of logic behind the study. As you can read here, we were hoping to look for biomarkers. I just wanted to give the results of that since these were presented at Croi. So they put 45 people into this study. They were all virally suppressed for 2 years. There was 33 people who started their medications while they were chronically infected, and there was 12 people who started right at the beginning of their infection during the early infection period. So that was the study makeup of those people. And here you can see some of the other information about them, predominantly white. But if you look at the early, we have predominantly Hispanic, and look at that, 50% Asian. So we're only talking 12 people though. But still, it's interesting to see that info. They didn't give me any info on male or female, so I can't report that. The step 1 of the study, they were getting a leukapheresis so they could get some of their cells. And then step 2, they started their, what they were calling the intensively monitored antiretroviral pause, or the IMAP, which was going to last up to 48 weeks if they made it. However, if they started to meet the restart criteria, in other words, they started to have a viral load of, I think it was 200 or 400 in every 2 measurements, and then they would go back to their ART. So step 3 was either a follow-up on ART for up to 96 weeks, or step 4 was follow-up off ART up to 96 weeks, although no one, I think, in this study made that category to step 4. What they found, that there was no consistent differences in the immune parameters between the early people and the chronically treated participants. And you can see here, this is what it looked like. So if you look at the red solid line, and then you look at the red dotted line, that's the people in the study. You can see how almost similar they were, no matter if they started meds first when they were chronically infected, or if they started right at the beginning of their infection. There was not much difference there. So some of the conclusions of this study was that there was no single immune marker that was strongly predictive of the time to rebound. There were some associations that they were noticing, but they need additional studies to determine whether higher levels of proviral expression and antigenic stimulation on ART may be responsible for immune activation and exhaustion. And they are going to be looking at that. So I just wanted to give you some of the results of this study itself. But the other thing that was interesting about Croi, which I want to get to, is that there was lots of COVID at Croi. So if you remember last year, Croi was shut down right as everyone was being shut down. And so they had to pivot very quickly. And so they had hastily planned session on the new coronavirus. But here it is a year later, and more than half the invited talks and a quarter of the accepted abstracts were related to COVID-19. And of course, you know that many of the HIV researchers and advocates have pivoted to focus on the new pandemic as well. So what a difference a year makes. But I wanted to look at one study that might be of interest to you all. This is about the underlying health conditions playing a major role in the increased risk of hospitalization with COVID-19 in people with HIV. So what I'm talking about here, this was the panel that was discussing this. I'm talking about 2 studies, and there are 2 studies that are going to at least partially explain that it's the underlying health conditions, especially heart disease and kidney disease, that make for higher rates of hospitalization or worse health outcomes after being admitted into the hospital. So the one study was done in Britain and the other one in the US. And when it comes to the British study, basically they found that the higher risk of COVID-19 in people with HIV was entirely attributable to underlying health conditions and greater physical frailty, where the US study had a little bit of a different conclusion. They found a small but statistically significant increase in the risk of hospitalization for COVID-19, even after controlling for the underlying conditions, meaning that it was the HIV that may have done this small but statistically insignificant increase in the risk of hospitalization. So 2 studies with differing results, but both of them noticed that a low CD4 count and underlying health conditions were really emerging as the key risk factors for hospitalization in people with HIV, not necessarily the HIV itself. So the British study really noticed that active malignancies and a higher clinical frailty score equaled a longer time spent in the hospital. For people with HIV, that meant about 10 days, where the control arm, the people without HIV, was about 7.5 days. And they were stressing the importance of appropriately matching in their case-controlled studies the people, so you can help clinicians to understand which people with HIV are at greater risk of worse COVID outcomes. And I think this isn't challenging. The American study which was showing that the rate of hospitalization and the rate of mechanical ventilation was higher in people with HIV, also and higher with people with organ transplants and HIV positive transplant recipients compared to HIV negative people. And so they were saying heart attacks were having a history of heart attacks made you 60% more likely to be hospitalized. Stroke and pulmonary disease, 50%, vascular disease, 43%, and congestive heart failure and chronic kidney disease doubled your chances of being hospitalized. Liver disease, diabetes, and cancer itself did not decrease the likelihood of people with HIV being admitted to the hospital. That's what the American study found. And so they were saying that although the effect of HIV on the risk of hospitalization was weakened when the analysis was adjusted for the presence of comorbidities, they still found that people with HIV in the US were at an increased risk of severe COVID outcomes. So I don't know what to make of that. And that's what I was hoping to talk about a little bit. We have two studies that have similar but yet different conclusions.
How did they rectify those two studies to make them, like, which study do you go by?
That's a good question, Bill. Rachel, do you have a answer?
Sure, maybe. Well, and then the other study that was presented by Adrian Shapiro that you didn't mention was also from us here at UW, but throughout the CNICS, so all of the CFAR or the 8 participating CFAR centers in the U.S. That included only people with HIV because it's CNICS, but out of more than 16,000 people in the CFAR registries, there were 583, I believe, cases of COVID diagnosed, and we looked at risks for being diagnosed with COVID, as well as risks for being hospitalized, again, among people with HIV. And we essentially found that there were no HIV-specific factors that put people at greater risk of being diagnosed with COVID, but that CD4 less than 350 increased the risk of being hospitalized with COVID. And thankfully, very few people in this group passed away, so we didn't have enough data to look at risk of death. But we really found that apart from that, we actually found one other thing that was really interesting was that people who had untreated Hep C were more likely to be hospitalized with COVID as well, which I think goes into the sort of immune exhaustion hypothesis that if your immune system is busy churning on a virus, it can't go pay attention to another virus with your T cells. And we saw most of the same things that were played out, I think, in the other studies of people both with and without HIV. I think part of what is really hard to look at from these big registry studies, again, with maybe the exception of things like CNICS, where we know our data is really good at ascertaining, cardiovascular disease and diagnoses of hypertension and hyperlipidemia and things like that, is that sometimes the data quality just isn't really good. And so it's really unclear as to how well some of these studies controlled for multiple comorbidities, meaning we know that people with HIV are, overrepresented in ethnic minorities and people of color who are more likely to be exposed to COVID. There are higher rates of smoking, higher rates of metabolic comorbidities that we know are all both increase people's risk of being exposed to COVID and increased risk of hospitalization. Mm-hmm. And so you have to have really, really good data to tease apart, is it HIV or is it someone who, because of HIV, comorbidities with HIV, has those comorbidities, and it's actually the hypertension and hyperlipidemia and obesity and diabetes and kidney disease that make it higher risk. And I think that apart from what we found with a low CD4 count increasing the risk of hospitalization, what we think after looking at this pretty carefully is that it's probably more of the pile-on of comorbidities and then exposures that makes sort of just being positive seem like it's more risky, among people who have, for example, great immune status, et cetera.
Hmm. Now, there's a topic for discussion, immune system exhaustion. I've never heard that before.
I think
Amen.
Michael brought that up with one of the A5354. So there's this idea that, and this is why we think that, you know, in some ways, having viremia not being suppressed is probably more important than CD4 count number in terms of risk of opportunistic infections and in terms of cancer risk and even metabolic risk, is that as your T cells, if they become really specific and to HIV or hepatitis C or another chronic stimulus, including cancer, that those cells get pooped out. And, you know, if you say to somebody over and over, jump rope, jump rope, jump rope, jump rope, or, you know, on a treadmill, you can only run a marathon for so long. And so, you know, that's why we sort of stopped focusing in some ways on CD4 count, and it's more suppressed and unsuppressed for personal health, not obviously for transmission. It's very important as well. But we can actually measure markers on T cells to see whether they're naive, whether they're specific to HIV or CMV or hepatitis C, and then also whether or not they're exhausted, so to speak. So it's a specific phenotype of cells that just says you can ask the cell, not ask the cell. I like to personify the immune system, but you can ask the cell, please spit out interferon gamma when I stimulate you with this virus, and they say, nope, too tired. So that's an exhausted T cell. And we know that being on treatment reduces that, and treating hepatitis C reduces that. And there's an ACTG study coming down the pike that looks at using a treatment for CMV in people who are CMV positive and with HIV to see if treating hep C also helps improve some of that immune exhaustion.
Interesting.
I have one last thing I wanted to point out from Croi, and it's a talk that I want you all to check out, and I'll send the link in the chat in a moment, but it's called Vaccine Nationalism is Killing Us: How Iniquities in Research and Access to SARS-CoV-2 Vaccines Will Perpetuate the Pandemic. And it was a great talk given by Greg Gonzalez and Fatima Hassan, and it was led by James Pickett, and he moderated for us. And there it is again, but I will send it to you in the chat. But, you know, it just calls out a need for people's vaccines. So this is some of what they were saying in this talk. COVID vaccines are a global public good, and we have surrendered it to the market, thinking the market will provide, and the market's basically saying, how much can you pay? And you can't wait for philanthropy to buy equality. It's not acceptable that the global South, that Black and brown people everywhere have to wait for vaccines. Everyone has to stand up, and they were calling for scientists to march with us. So a people's vaccine, free from patents, and not a profit vaccine, just kind of like what Jonas Salk did with the polio vaccine. When he was asked about it, he was like, hey, how can you patent the sun? He was saying that this was for everybody. So there is a call that you can look at, and I will put this in the chat after I'm done here so we can get to our next topic. But following this, there's a call for a global vaccine equity, and you can sign your name to this. These are some of the things that they were going for.
In that link that you're going to provide us, is there a way to sign our names to it?
Yes, that's exactly what it's for.
Okay.
Yes. So let me stop this right here, right now. Okay, because I want to get this up. The second part of what we wanted to talk about, let me get this first. I'm going to copy all of these. All right, hold on. And we wanted to talk to you about something that we've been thinking of, which is renaming our clinic. And we wanted to get your thoughts on what renaming our clinic might look like for you all. So before I let Rachel talk, I just wanted to point out to you that this is something that happens with a lot of groups that have the word AIDS in their name. And moving to a different name is one of the ways that they can sort of try to rectify some of the things that might be happening. So for instance, AIDS does not describe our current situation where most people do not have AIDS. Most people are living with HIV. and the word AIDS itself still carries a lot of stigma, and that might keep people from associating with a group with AIDS in its name. And so here's some examples, both local and in the neighboring area, of people who have of groups that have changed their name. AIDS.gov became HIV.gov. Here locally, Lifelong AIDS Alliance just became Lifelong. Up in British Columbia, they had the British Columbia Persons with AIDS Society, which just became Positive Living BC. So we are looking at changing our name, not only for that reason, but because we also do more than HIV research at our clinic. So here's the name that we're talking about specifically. We are called the University of Washington AIDS Clinical Trials Unit, and we wanted to get your ideas and your thoughts on changing the name.
Is that going to be happening throughout the ACTG? Because aren't all the ACTG sites ACTUs?
I don't know that there's a plan to change ACTG as a network right now, but and they're not all called ACTUs. Some of the clinical research sites also do HIV Prevention Trials Network and HIV Vaccine Trials Network. And, as you know, this ACTU has done pharmaceutical studies, does observational studies, and defeat HIV, observational studies. And so we're not obligated to stay with that name. We may keep it kind of in parentheses for, on regulatory things, just because, I don't know, we'll have to kind of investigate how hard it would be to remove from kind of like the legal documentation. But it could be something where it's more of an internal use, and the external use is what we all would like it to be called. Again, this is just something, as the new director, I just feel like this is a time when we have a time for a refresh. And if people are happy keeping ACTU, I'm happy keeping it. I just wanted to make sure that it matched what everybody was sort of feeling was, where we wanted to be and how we wanted to present ourselves to people who might be looking to participate or be in our community.
And I know that, there's been some disconnect. So for instance, we were, with this shutdown, we pivoted into doing COVID research, but having people who've never heard of us, who might be interested in that COVID research, coming to the AIDS Clinical Trials Unit, that you can probably sense that there was a little bit of a, what's going on? Where if you're closer to research, you might understand what was going on. But for that person who's never even considered research before, we were wondering if the name might be limiting who might come to us.
What about UW infectious trial units?
Yeah, or something like that. Yeah.
It's more of a broad infectious. You're not just dealing with AIDS or HIV. You're dealing with all kinds of infections.
Mm-hmm.
I'm not entirely opposed to it. We aren't doing general infectious disease research. It mainly is around STIs and HIV. And hepatitis. And some people do find the term infectious stigmatizing as well. I defer to people who are in the community about that. I don't know that I would go sort of that broad with it, because we're not sort of a general infectious disease.
Okay.
Yeah.
And also, we're looking for your ideas right now, but this isn't the end of the conversation. It's not like this is the beginning of it. We're going to be looking at, taking some time with this and exploring options that we have. But I wanted to introduce the idea with you all here and to get you thinking, because, sometimes ideas pop up when you are taking a shower, for instance. When you're not thinking about something is when the good ideas come.
That you do.
So, but we were just looking to get your impression. Do you feel like there's a need for a name change? If you've ever been to our clinic, do you feel like there's a stigma associated to the word AIDS?
Well, I'm from the old school, you know that.
Yes.
And, there's such a history there.
Yes.
A deep, deep history. And the first time you discussed the name change, I understood it, but I thought that seems, you know, I've said this so many times. We stand on the shoulders of many giants, and many of those giants have walked through ACTU.
Hmm.
And, you know, it's, I think just preservation to me is so key because AIDS is already being forgotten. You know, and it seems like we're feeding that too.
Yeah, I
But
think
that's
that's a great
just
point, Bill.
that's just me, you know, the old fogey.
No,
I
no,
think it's a
no.
great point, and I think that's one of the considerations of keeping a hybrid name. So potentially, if we wanted to not have HIV or AIDS in sort of a title, like Michael had brought up, research with a heart is the name of the Rutgers equivalent, our equivalent at Rutgers. Um, uh, so something like that, but it could still be sort of UW ACTU in parentheses, to sort of keep the history there as well. And I mean, I think that's something as I'm taking over from Anne, you know, I don't want to erase her contribution or all of the participants' contribution, but just trying to strike that balance of sort of what is fresh and future looking with what honors the past.
I'm also one that call a spade, call it what it is. Don't hide behind acronyms.
Hmm.
I've always been that way. You know that, Michael. I call it how I see it.
Yep.
But I think if you do decide to change the name, like she was saying, keep it in parentheses or whatever underneath it, that University AIDS clinical trial units.
Hmm.
It's still the same thing because it confuse a lot of people. Somebody maybe that's been dealing with HIV for a long time knows somebody that's newly diagnosed and refers them to the University of ACTU, and it's no longer called ACTU. You know, so I think you should keep that in there and keep a link to that as well, so that when it change, if you do change the name, that when you go do a web search for it, it's still going to pull it up.
Yeah, we would want to make sure that search engine still found us.
Yeah.
Hmm. Well, I wanted to bring the idea up for you all because I wanted you to think about it and to share your honest assessment of the idea, you know. And so, Bill, I really honor what you share and what you say because I, in a sense, feel the same way you do. And I think that, you know, there is a history that we want to keep a hold of. I also see from a different angle, like for someone who's newly infected, who doesn't know anyone who's ever had AIDS, does the name detract that new blood from coming into our clinic? And do we need to think of some way of trying to embrace those newer people who may never ever reach AIDS? So not wanting to forget the past and not wanting to disrespect the past, and yet wanting to welcome in the future. That's kind of where we are. And it's not really anything that is a solidly decided thing. So we may bring this up, and we might have a year's full of conversation to end up staying exactly where we are right now. So I just wanted to kind of let you all know that there is no change planned in the immediate future. We just wanted to start the idea now because now would be the time, if we were going to change, that it would make the most sense to change. You know, it's been a whole year of changes. And so, Rachel, I had someone ask me also, is there any sort of update about Anne that you could give to the CAB?
Oh yeah, absolutely. Anne is doing very well. I see her on Zoom, if not in person, once a week. She's working 25% of the time. So as a quick recap, I don't know if everybody on here is aware of what happened to her. She's totally fine sharing. She had a benign brain tumor that was emergently removed in September. So while it hasn't come back, it's not cancer and it wasn't a risk to her. It was a big enough tumor that it just was an incredibly long surgery and was pressing on enough vital structures that it's left her with some deficits. She's working really hard on physical therapy and occupational therapy. She looks good. She feels good. I don't think she, is in any discomfort or anything like that. she just, isn't quite back at the level that she used to be at before. So that's why she's not currently not planning to see any of her any clinical work again in the future, but is still working on some of her research projects. And it's great to have her as sort of an advisor. Is sort of the way that she's been working with me, is that I've taken all of the load of the work, but she's there to give context and advice and wisdom.
Sweet.
I think it would be nice if every once in a while we, all send her a card or something.
Absolutely.
Or
I can also
recorded
see.
one.
I can also see if she would be interested in coming to a cabin, just saying hi. I think she may or may not. I don't think she feels that confident at being on camera, just because she speaks a little bit slower than she used to. I think she's pretty fine, and I think that everybody will also be very understanding of that.
Maybe we should get a card that we can all sign virtually and send out to her. What do you think, Michael?
Yep, we can work on that. She did get our video that we made for her. We did that recording of all those get well wishes.
Yeah.
Yeah, that was a while ago.
Yeah.
Rachel, can you please let her know we were asking about her at the meeting today, and that we send her our good wishes, and then at some point in the near future, maybe we could, do the card thing.
Oh, absolutely. I absolutely will. And I know that she's, she thinks about everybody. She's, always asking me about people she's taken care of for years and years and years. I know that I don't know whom of you all she was the physician for, or just a research and community relationship with, but she's asking about everybody, and I know she misses being at work for sure.
All right. Well, I just wanted to end the meeting here by making sure that you all know that our next meeting will be on April 27th at 5:30. And I already have some things lined up, including, I don't know if you'll remember the name, Jennifer Manuzak. She was a part of the cannabis study that we had going on, and she's going to be coming back to talk about more cannabis-related research. So that'll be on the 27th of April, and you don't want to miss out on that. We'll also have some other researchers stopping by who are going to want to talk about how COVID has affected people living with HIV, and they want to get some of your impressions on that as well. So that'll all be for next month on the 27th. But let me stop sharing here so I can see all your smiling faces one last time. Thanks to those of you who have made it to the end there. I hope you saw that in the comments section I put up the links that you may want. So if you were wanting to get the Croi abstract book, or if you wanted to see that vaccine, Nationalism is Killing Us, or if you wanted to sign the Global Vaccine Equity, all of those links are right there, and I'll keep them up as we say goodbye, so you have a chance to click on them all, so you can bookmark them if you want.
Are those links going to also be included in the YouTube one?
Yes. And I'll send them out as an email.
Okay.
I'll send them out as an email to you as well.
Perfect. Well, it's nice seeing everybody. Have a good day.
Thank you. You all be well. Manuel, Laurie, Bill, Kate, Rachel, thank you. Glad to see you.
Hi, everybody.
All right.
Bye,
Bye,
everyone.
everybody.
Bye, everyone. Stay healthy.
Yes, you too.